Hey guys, I'm going to go ahead and do a recording for you for this week so that you can get some of the content that we would have had this week. Um, so I was trying to figure out if I want to do one of my own PowerPoints with you or not. I think maybe we'll do something different here. Okay, so let's see here. Pull up. Let me see if I can pull up something that might make a little bit more sense, I hope. So it looks like this week you guys have been talking about asthma and COPD and cystic fibrosis and stuff along those lines. So I'm going to see if I can just talk about asthma and COPD and maybe a little bit about cystic fibrosis for you, and then we'll kind of leave it at that. If there's anything in particular that you're having a hard time with, please let me know, and I'll see if I can, make it a little easier for you to understand. Okay. Let's see if I can get this pulled up better. This is a PowerPoint that I did with one of my other classes that I teach. I can only get it to open better. Thing has to take forever. Well, I guess I could do it like this. Okay, so I just put in here, stuff about normal lung function, just so you kind of get a basic understanding of what your lungs do. So as you inhale air, oxygen travels into your upper respiratory system through your nose and your nasal cavities, down your larynx, down into your lower respiratory system via your trachea, which splits into the carina into the right and left primary bronchi. The primary bronchi and primary pulmonary artery and vein, which are from the heart, enter into the lungs at the hilum. And the primary bronchi break down into smaller airways that are secondary bronchi and tertiary bronchi. Then air enters into the bronchioles, alveolar ducts, and alveolar sacs for gas exchange. Here we go, now we're in business. So your diaphragm helps your body inhale and exhale air. The diaphragm will contract downward, which causes negative pressure in your lungs, and then this allows air to rush into your lungs. The diaphragm relaxes back into a dome-shaped position, which allows the high pressure that is built up in the lungs to be forced out with exhalation. The alveolar sacs contain capillaries that supply the pulmonary artery, which takes unoxygenated blood to the lungs to receive oxygen, and the pulmonary vein, which takes oxygenated blood back to the heart to replenish the body. These capillaries have a thin membrane that allows transport of oxygen and carbon dioxide. Okay, so this is where we start getting into a little bit about asthma. So we'll talk about that first. Okay, so basically what is asthma? It's a chronic lung disease that doesn't have a cure, but what it does is it causes narrowing and inflammation of your airways, and it leads to difficulty breathing. So when someone has an asthma attack, there's different things that can trigger that. So that's kind of a big part of this, is like some of those triggers that you would need to know. So there's a ton of things. So there's environmental triggers, where it could be smoke or pollen or pollution, perfume, dust mites, cold, dry air, mold. And then there's like body issues. So like you could have GERD, and that could be your trigger that triggers your asthma. Hormonal shifts, exercise-induced asthma, and then even taking in certain drugs. So beta adrenergic blockers that are non-selective, NSAIDs, aspirin, preservatives like sulfites. There's literally a ton of things that can trigger this. So it's not always just, an environmental thing. It can be other things. So just kind of remember that, keep that in mind. Okay, so when you are having an asthma attack, some of the things that you normally would see would be chest tightness, wheezing. Usually that's the number one thing you're going to see is the wheezing. Sometimes it gets so bad that you can hear it without even putting your stethoscope on someone. Coughing, difficulty breathing, especially exhaling, increased respiratory rate. And then this can progress to where it's so bad where your rescue inhaler won't work, you can't talk, you have chest retractions, you're just like really working to breathe, you get cyanosis of your lips, and you get sweaty, and you need medical attention really fast. So one thing I want you to remember is allergies are one of the strongest predisposing factors for asthma. So if you're allergic to a lot of things, that's going to be a problem for you. So three of the most common symptoms of allergy, or not allergies, but asthma would be cough, dyspnea, and wheezing. And then when people have exercise-induced asthma, they may feel like a choking sensation during exercise where they just feel like they're choking. Okay, so I have a bunch of words here, and I know you maybe don't want to feel like reading through all of this, but basically what you need to know with what's happening pathophys-wise with asthma is there's three things going on. So you have bronchial smooth muscles that, line your airways. And those muscles will like clamp down during an asthma attack. They'll like really, get small. You also have swelling that goes on in those airways as well. So now you have swelling and those muscles are clamping down together. And then also you have a third thing going on. You also have a bunch of mucus that's producing during this attack. If you read through what I have on the slide here, it talks about you have goblet cells that are in that mucosal lining of your airways, and those goblet cells produce mucus. And the mucus is supposed to help trap irritants and bacteria to prevent these substances from entering into your respiratory system. So during this attack, everything just is, overly working, I guess you could say. So it makes it even worse. In this picture here, you can kind of see what's going on. So here's a normal airway. Here's someone with asthma. So again, here's that smooth muscle that lines your bronchioles. So you have that can kind of relax or constrict. During an asthma attack, it constricts. And then inside the airway, you have swelling going on. So things are getting really small in here. And then you also have mucus producing in there. So anyway, during this asthma attack, air is becoming trapped into the alveoli. So gas exchange is not taking place, and you get low amounts of oxygen that enters the blood, so you will have a decreased oxygen saturation. And your carbon dioxide is staying in the blood, so you're going to get respiratory acidosis with this. So the person just feels like they can't exhale all the way. So first of all, if you know someone has asthma, things that you want to consider would be, hey, I need to know what my triggers are. So if you know what you're allergic to or things that make you, go into an attack, you avoid those, And there's a lot of things that you can do yourself just to help prevent that. So like if you know it's dust, then you need to really keep your house super clean so that you stay away from that. There's just a number of different things you could do. There's like HEPA filters for your vacuum. There's the air purifiers, you name it. There's a ton of different things you can do. And even when you look at bedding in the store, they have hypoallergenic bedding that you can get that, covers your mattress or your pillow, and that may help a little bit. So those are some of the things that you could do to prevent, But if someone does have an asthma attack, things that you would do as a nurse for this person, you would want to get a baseline set of vitals. You want to try and keep them as calm and comfortable as you can. You definitely want to have them sitting up in a high Fowler's position because, if you're sitting up, you can breathe easier. Um, Administer bronchodilators. So the bronchodilators would be like your albuterol. That's going to open up those airways so that they can move air a little easier. You're also going to administer oxygen. You want to see their oxygen saturation between 95 to 99%. And if this is someone who frequently has asthma attacks, like if you would call them like a moderate to severe asthma person, then they should be doing peak flow meter readings. So this person should be watching for numbers less than 50% of their personal best reading. So by doing that, you can help prevent, this from getting worse. So you would have to talk to them about doing that. You as the nurse would be auscultating the lung sounds throughout this attack. You want to see a decrease in the wheezing, and you want to see that they're having an easier time breathing, that their respiration, their respiratory rate is going to go down, and they just seem more comfortable. You're going to monitor their skin color for any kind of, obviously if you have blue skin or gray or whatever, obviously you're not oxygenating well. So you're going to be watching for those things, and hopefully you're going to be pinking back up because things are improving. Other things, when you're really working to breathe, you're having retractions of your chest. Sometimes people can't even hold a conversation with you whatsoever because they can't talk because they're so short of breath. So if that's getting better, things are doing well. And then again, with this peak flow meter, this is something that they should be doing. So the peak flow meter, typically someone should have an asthma action plan. So I don't know if you guys have ever looked at one, which I don't know if I have one right here or not. Anyway, you can get on the CDC website and print one out, which I can't find mine at the moment. But anyway, you can print it out and it totally tells you, oh, here it is, all kinds of things that you need to know. So I wish you guys were here so you could see this. But basically, it kind of looks like this. So you have a green area, a yellow area, and a red area. So at the top of the asthma action plan, this is something, your doctor would fill out with you if you had asthma. So at the top in the green zone, that's where you want to stay. So that means that you're doing well at the moment, that you don't have a cough, you're not wheezing, you don't have chest tightness. You can do your normal activities and you feel pretty good. So it also has a spot there that talks about the peak flow meter. So if they did a peak flow, and this is just a little device that's probably, I don't know, maybe this long. The ones that I've seen at the hospital are white. They don't necessarily have to all be white, but basically there's a mouthpiece that you would blow into at the end, and then there's a meter on the one side of it. So as you blow out, so you basically take a deep breath in and blow out as hard as you can, and then into this meter, and it'll make this little lever go up, and you look at that number, and that's what we're talking about with these peak flow meter numbers. So anyway, on this green zone where we want to stay, we want to see a peak flow reading of 80% or more of your best peak flow that you've ever had. So like, I don't know, say my best peak flow was 400. So for 80% of 400, it would be 320. So I would have that up here. So you want to see that you're anywhere from 320 to 400 all the time. And that means that you're in that green zone. Now on this asthma action plan, it also has a spot where you can write medicines that you should be taking daily. Now, if you know someone has asthma, if they take stuff daily, it's going to help them so they don't keep going into these attacks. So it's kind of preventative, So there's long-acting medications that we can give. So like in my other class, we do kind of a case study that goes along with this, and we actually fill out this asthma action plan. So in this case study, this person had 3 medications that we put up here that they take daily. So salmeterol was one of them. Salmeterol, the other name for that is Ceravent. So this is a long-acting beta-adrenergic agonist. So that would be something they would take daily, and it's just an inhaler. Okay, so it's not something that you would reach for in if you were having an acute attack, because it wouldn't help you. This is just something that is long-acting that you take daily every 12 hours. Another thing this person took was Flovent, which that's another inhaler. This is a combination inhaler. It has 2 different things in it. So it has, I think it has a steroid in it and something else. I forget what the other thing is. But anyway, again, that's not something you would reach for in an acute attack, when you're really having a hard time breathing. And then the third thing on here was cromolyn sodium, which is another long-acting thing that you would take. This is a nasal spray, and this person takes it daily and before being exposed to known asthma triggers, and they can use it up to every 4 hours if they need to. So that's also another long-acting thing. Okay, when you go down this asthma action plan, the other thing is under the green zone, there's a yellow zone. So the yellow zone means that your asthma is getting worse. So in this section, it talks about, hey, now I'm having coughing, I'm wheezing, I have chest tightness, shortness of breath, I'm waking at night due to asthma. I can do some, but not all of my activities. So it has a thing about the peak flow here. So it says, hey, if you're doing your peak flow at home, it's between 200 to 316 here. So if I fall within that range, I know I'm starting to have an issue. I'm in that yellow zone. So to the right of that on here, there is a thing about medications and what you should do. So it says you should take your albuterol on this particular example. So this person should take their albuterol. They can do 2 to 4 puffs. I think it was every 20 minutes for up to an hour. And then it says, if your symptoms and peak flow do not return to the green zone after an hour of the above treatment, then you need to do it a little bit more often. And then if that doesn't help, then you call your doctor. And it says if you had no improvement after a couple of days. So then the bottom part of this is the red zone. That's where you don't want to be at. So if you're in this zone, you're really short of breath, your quick relief medicines haven't helped you, you can't do any of your normal activities, and your peak flow is less than 200. So this person is going to reach for their albuterol inhaler. They're going to do it pretty often for a while, and then if that doesn't work, then they're going to call 911 or go right to the doctor. So this kind of tells you everything that you should be doing to kind of prevent things from getting worse. Now at the bottom, it also even gives you danger signs. So it says if you have trouble walking and talking due to shortness of breath, if your lips or fingernails are blue, if you have anything like that, you need to go right to the hospital. Call 911, don't mess around. So that's the asthma action plan. Okay, I also have a couple of things on here about medications. Let's see if I can tell you guys a couple other things. Oh, again, with this peak flow meter, let me just say a couple more things about that before I go on to the medicines. The peak flow monitoring measures the highest airflow during forced expiration. So daily peak flow monitoring is recommended for patients who have moderate or severe asthma, and peak flow monitoring helps to measure asthma severity. A patient's personal best peak flow is measured after 2 to 3 weeks of optimal asthma therapy. This can be used on the asthma action plan. Okay, so then with medications, you need to know the difference between what is a short acting and what is a long acting medication. So if you're reaching for something short acting, we're typically reaching for albuterol. That's, the number one thing you're going to do. Usually it's an inhaler or a nebulizer, and it's a fast acting thing. So if you're really having shortness of breath, that's going to help fix that. Long acting things would be stuff like that salmeterol, like I was telling you about on this asthma action plan, or Symbicort, something along those lines. These are not for an acute attack, and you do get a little bit of side effects when you take these medicines sometimes. So you can get tachycardia, very jittery, your heart rate sometimes goes up, sometimes you can have a dysrhythmia. So you have to watch, when you're giving people that. Some people take anticholinergics, so there is ipratropium, which is Atrovent. This is also a short-acting medication. So albuterol and Atrovent both are short-acting. So this relaxes the airways, and usually people will use this if they can't tolerate albuterol. Like I said, albuterol can make your heart rate go up. So like say that's an issue with someone, then you would just do that Atrovent instead. I'm sure you guys have anyone who works anywhere has seen people take Spiriva, which is an inhaler. That's what this one is. This is a long-acting inhaler, and it comes with a pill that you stick in it, and you poke a hole in the pill, and then you inhale what's in the pill. So lots of times people will have dry mouth from that, so sugarless candy can help with that. And then this is a medicine that everyone should just kind of keep in the back of their head. I don't really think that it's used that much anymore, but occasionally you might see someone who is on it. So theophylline is something that they used to give years ago for problems like this, and it was given by mouth. But the reason that we don't do it anymore is because you have to have a decent blood level of it in your body for it to work well. So if it's too low, it's not going to work. If it's too high, it's going to be toxic. So it's kind of not as safe as some of the other things. So you kind of need to know a little bit about that. And then of course, anti-inflammatories would be things that, if someone was admitted to the hospital with an asthma attack, sure, you could do that for a short period of time with them. A lot of times people will get like prednisone for a little bit while they're in the hospital, and that's to help, with that inflammation that they currently have going on, and you would have to taper them down. So it's not something that they would stay on. It would be something short term. And then at the bottom here, I mentioned leukotriene modifiers. This is, I'm trying to think of the name of this. Let me see if I have it written down. Singulair. I can never remember the name of that. So Singulair, and it's a pill form as well, and it works great. So my daughter had to take that when she was younger, and it worked really well. So that's another thing that sometimes people will take, but it's long acting. So really, every med is pretty much long acting except for albuterol and Atrovent. So if you can kind of think of it that way. All right, the next thing we're going to talk about is COPD. So instead of looking at all of my stupid slides here, because I don't really like how I have this done, I'm going to pull up something else because I think maybe that'll make more sense. Okay, so this is on that registered nurse RN site. She's got a bunch of stuff, and honestly, sometimes she just makes it a little simpler with what she says on here, so I'm just going to go with what she's saying. So with COPD, this is a chronic condition of where you can't get good airflow in your lungs. And the reason for this is because you've had damage to your lungs in some way that's irreversible, that you cannot fix. So in here she says it's a pulmonary disease that causes chronic obstruction of the airflow from the lungs. So this is because you have thick, swollen bronchioles that have become deformed, and also excessive sputum production that narrows the airways. So you see there's like a big correlation between asthma and COPD, except with asthma, you don't have like the actual damage to the lungs like you do with COPD. It's like more, it's different, you know? So again, this person is going to feel like they don't have the ability to exhale fully. So like they can inhale with no problem, but they can't get all of their air out. This is because they have a loss of elasticity to the alveolar sacs because of all the damage that's starting to happen to the lungs. So again, some people can have like mild COPD and some people have really severe. It's not something that happens quickly. It happens gradually over time. Usually people start to notice signs and symptoms when they're middle-aged, and then they'll present with shortness of breath, with activity, and then they'll have recurrent lung infections and chronic cough and all these things. So COPD is kind of a catch-all term for the disease process. Usually you have a couple of things going on. You have emphysema and also chronic bronchitis. So in here she says, hey, emphysema is also pink puffers. I don't know if you guys have ever heard that term before. Actually, I think I have a picture of this on my other slide, so let me stop this for a second. Let me show you that. Here we go. So a pink puffer. So basically, like if you have COPD, you can have aspects of emphysema, or you can have aspects of bronchitis, and then some people have aspects of both. So it doesn't always look the same person to person, is what I'm trying to say. So the person that has COPD that is more emphysema-like, this is the person who really has a lot of damage to their lungs. So they have increased CO2 retention, but they are still perfusing okay. So they're still getting good blood flow to their lungs, so they're pink. They don't look like they have blue skin or anything. This is the person who typically will have a hard time breathing. They do that pursed lip breathing a lot. They have the barrel chest, like you can see in this picture. They seem anxious all the time, I guess you could say. Usually they're really thin in appearance. They use their accessory muscles to breathe. Typically you'll see them speak in real short sentences, and they're always like sitting in that tripod position to try and breathe better. So that's the emphysema person. The blue bloater person is the chronic bronchitis side of this. So this person, they have an airway flow problem. So they have a bluish color to their skin. Their color is dusky to cyanotic. This person has, and maybe both people have the cough, but this person more so. So they have like lots of sputum production that they produce. They're hypoxic. They are retaining CO2. They have respiratory acidosis, increased respiratory rates. And then look at the bottom of this. It says you can get cardiac enlargement. You will end up with right-sided heart failure and bilateral pedal edema with this as well. Go back to the other screen here. All right, so what's going on pathophys-wise? So they say inhaled oxygen travels down through the trachea, which splits into the carina, into the bronchial tubes, starting with the primary bronchus into the smaller airways. As the alveoli inflate and deflate with ease, inhaled oxygen attaches to the red blood cells and carbon dioxide enters the respiratory system to be exhaled. That's what happens normally. But with COPD, this is what happens. Um, so, like with the blue bloaters. So, this is because you have um, hypoxia and bloating from this edema, and increase in lung volume. The bloating is from the effects of lung disease on the heart, which causes right-sided heart failure. In chronic bronchitis, the bronchioles become damaged. That leads them to be thick and swollen and deformed. This is accompanied by more sputum production, and it limits the ability of the person being able to completely exhale the air that's taken in. So when they take in another breath, it increases their air volume even more because they already have retained air there, and this leads to hyperinflation. So their lungs are always inflated. Also, less oxygen is getting into the blood and more carbon dioxide is staying in it. So that's why they have the cyanosis, because of that. So to compensate, the body increases red blood cell production and cause blood to shift everywhere, which increases pressure in the pulmonary artery, and this causes hypertension. So pulmonary hypertension leads to right-sided heart failure. So that's kind of the blue bloater side. And then with the emphysema, again, you have hyperinflation, so they're puffing to breathe. They do have a pink complexion. They may maintain relatively normal oxygen level due to their rapid breathing. In emphysema, the alveolar sacs lose their ability to inflate and deflate due to an inflammatory response by the body. So the sac is unable to properly deflate and inflate, and inhaled air starts to get trapped in the sacs, and it causes major hyperinflation. And this is why they get the barrel chest. Anyway, the damage to the alveolar sacs causes the body to keep high carbon dioxide levels and low blood oxygen levels. Inhaled oxygen will not be able to enter into the sacs for gas exchange, and carbon dioxide won't leave the cells to be exhaled. Okay, so let's get into the signs and symptoms a little bit. So remember, again, with asthma, you don't have actual lung damage. You have certain things going on when you have an attack, but with COPD, you actually have lung damage. That's the difference. So this person typically will have a lack of energy. They'll be unable to tolerate activity, so they always have shortness of breath no matter what they do. They usually have poor nutrition, a lot of times weight loss that goes with this. Their blood gases are abnormal. Usually they have respiratory acidosis. They could have a dry or productive cough that's constant, especially with the bronchitis. And then their skin color could be pink to cyanotic in their lips, mucous membranes, and nail beds. Again, they can have that difference in their anterior posterior diameter of their chest, which is that barrel chest, because of constantly having these hyperinflated lungs. And again, they get in that tripod position during their shortness of breath attacks, which is like leaning forward while supporting their body with their hands or knees on an object. They have extreme dyspnea. In turn, over time, people with COPD will be stimulated to breathe due to low oxygen levels rather than high carbon dioxide levels. So this is why you kind of want your COPD patient to live at a normal low oxygen level. Like, you know how normally we're always like, oh, we want someone's pulse ox to be, 92 or above. Well, the COPD patient, you might be okay with them at 88% because the lower their, as long as they're okay and they're not like having issues, you're okay with that because they need to be stimulated to breathe, and that's what stimulates them to breathe, is having that low oxygen level. Okay, complications of COPD. So again, you could get heart disease from this, so you can end up with heart failure, right-sided heart failure. You could get a pneumothorax. This could be a spontaneous one because of the problems with your alveoli. You could be at risk for pneumonia and also cancer, especially lung cancer. Usually this is going to be diagnosed with a test called a spirometry test. This is where the patient would breathe into a tube and it measures how much volume is in the lungs on inhalation and exhalation. So that's something respiratory typically does, and it's not a very difficult test to do. And then interventions for people with COPD. So you're going to assess their lung sounds because they might need suctioned or something because they have all this sputum. If they have a lot of sputum, sometimes the doctor will want you to do a culture to see if they have an infection going on, so that could be something that you would do. And here's the thing about that low oxygen level. So we want a COPD patient's oxygen level to remain between 88 and 93%. So patients with COPD are stimulated to breathe due to low oxygen saturation rather than high carbon dioxide levels, which is opposite for the rest of us, right? So if they're given too much oxygen, it will reduce their need to breathe and it will cause hypoventilation and they'll just like quit breathing. So you definitely need to watch how much oxygen you give them. You have to be careful with that. We want to give oxygen in low amounts, about 1 to 2 liters. And then we want to monitor the effect of some of these techniques that we're teaching them, like pursed lip breathing and diaphragmic breathing. Pursed lip breathing is used when the patient starts to get dyspneic. This technique increases the oxygen level and encourages them to breathe out longer. So it's similar to like blowing out a birthday candle. That's kind of how you would describe it. Diaphragmic breathing uses your abdominal muscles for breathing rather than your accessory muscles. It helps make your diaphragm stronger, which is weak. It slows down breathing rate to allow breathing to be easier, and it decreases energy used to breathe. And it's used along with pursed lip breathing as well. And then, of course, we're going to give medications to the COPD patient. It's going to be very similar to what we do for the asthma patient. So bronchodilators, and typically, sometimes other things too. So nutrition, we want this person to eat a high-calorie diet, protein-rich meals, small meals, but frequent, and stay hydrated. Avoid large, heavy meals due to compression on the lungs from the stomach. This person needs to stay away from sick people, irritants, hot, humid, or very cold weather. Stop smoking or being around people who smoke because that's going to make things worse for them. They need to have their vaccinations up to date. They have to get an annual flu shot and a pneumovax every 5 years because it's very hard for people with COPD to recover from illnesses. Once they get sick, like say they get pneumonia or something, they really have a hard time. It's hard for them to recover. And then other medications that we might give. If someone came in with an exacerbation of their COPD, we could have them on steroids for a little bit. If they actually have an episode of bronchitis where they actually need an antibiotic, they might be on that. And generally, the same types of things that we do for an asthma patient with the inhalers and things we're going to do here. Okay, the things that she mentions here about medicines. She says, remember the mnemonic, chronic pulmonary medicines save lungs. So corticosteroids, they decrease the inflammation and mucus production in the airways. So they can be given orally, IV, inhaled, or used in combination with a bronchodilator. So just remember, when you're given a corticosteroid, you have things that can happen. Like you can bruise easily, you can have hyperglycemia, you can be at high risk for infection. You can have bone issues, so you can be at risk for fracture if you use it for long term. Usually you can develop thrush. There's a ton of things like side effects, so just remember those. There's also something called methylxanthines. This is where that theophylline comes into play that we talked about with asthma. Same thing here. So when you are on that medicine, you have a narrow therapeutic range. So you have to stay between 10 and 20 micrograms per milliliter. If you're not there, then you can be toxic or it's just not going to work well for you. There is also a specific medication that is used for COPD patients called a phosphodiesterase 4 inhibitor. It's Romuflast. This is used to treat people who have chronic bronchitis, and it works by decreasing COPD exacerbations. It's not a bronchodilator, though. Let's see. And then, of course, they have the short-acting bronchodilators that they could use just like the asthma patient, so albuterol and Atrovent. And then the long-acting ones, you know, the daily things that they take every day, like your Spiriva or your Salmeterol or something along those lines. So that's COPD. All right, give me 1 second, and I'm going to pull up the thing about cystic fibrosis, and we'll just end with that. Okay, I'm just going to stick with this. So cystic fibrosis. So this is a genetic disorder that you get. It's caused by your exocrine glands working incorrectly. So it can lead to some major complications that can affect either you respiratory-wise, which I think that's what most of us think of when we think of cystic fibrosis, or it can affect you digestively as well. So your exocrine glands are glands that produce and transfer secretions. So like your mucus, your tears, your sweat, your digestive enzymes, and they work via these ducts to intended area of the body rather than directly into the bloodstream like your endocrine glands. So this cystic fibrosis gene, it's a protein that controls the channels of your sodium and chloride, and it works to control sodium and water transport in and out of the cell. So these channels that are within the membrane of exocrine cells that make our sweat, mucus, tears, and digestive enzymes don't work right. So the substances produced by the exocrine glands don't do what they're supposed to do. So for example, your mucus is supposed to be thin and slippery, which helps lubricate structures, but in someone with cystic fibrosis, it's thick and sticky. So like in your lungs, the upper sinuses, you can get formation of polyps, blockage of the airways over time that leads to pulmonary diseases like emphysema, clubbing of the nails, those types of things. These guys are very susceptible to lung infections. And then, so that's the lung part of it. And then there's also a gastrointestinal part of this. Your pancreas makes your pancreatic enzymes, right? So these substances are secreted via your pancreatic duct into your duodenum, and it helps you digest proteins, fats, and vitamins. So again, because we're having this issue now with this gene, now this isn't going to work right. So now we're having trouble digesting things. So another thing that can happen is you can get diabetes from this as well. So things that you would see, you know, if you had this problem, you could lose weight really easily. You could have malabsorption, delayed puberty, greasy, odorous stool, bloating, and abdominal pain. So a lot of people who have this issue have to take pancreatic enzymes when they eat to help them be able to digest things. And then there's other issues that she talks about here too, about the liver, infertility, some stuff with your skin. The sweat glands produce too much salt. Therefore, the sweat and tears are really salty. The patient is at risk for electrolyte complications and dehydration. All right, so some different facts about cystic fibrosis. It's most common in Caucasians and males, but it can affect any race or gender. The life expectancy in 1960 was only 10 years old. Today, the median life expectancy is 37, which still isn't the greatest, but it's better. This is the most common detected in the first year of life. The child will have GI and respiratory issues. And then severity depends. Not all patients are 100% alike in their severity. This is an autosomal recessive disorder. That means the child has to have one mutated gene from both parents. In most cases, the parents are carriers of the disease but don't have the symptoms of cystic fibrosis. So to diagnose this, they do something called a sweat test. This measures the amount of salt in the sweat. Pilocarpine and electric current is applied to the skin to help it sweat, usually on the arm. A gauze is used to collect the sweat, which is sent to the lab to measure the salt in the sweat. To be positive for cystic fibrosis, it has to be 60 millimoles per liter. So to treat cystic fibrosis, the main focus of treatment would be trying to deal with this mucus, so you're doing things to help get that loose, to get it out. Help them with their nutrition. So, typically their nutrition isn't the greatest, so if you can do things to help with that. And then treat, excuse me, treat infection. Most patients will die due to a lung infection of some type, so prevent blockages in the GI system as well. All right, so usually people with CF are on a ton of medications. They have to do stool softeners, pancreatic enzymes, nasal sprays, vitamins, antibiotics, anti-inflammatories, mucolytics, and bronchodilators. So with the mucus, a huge part of everyday routine would be chest physiotherapy. They do the postural drainage, and they also do, the nebulizer with the huff coughing. So chest physiotherapy helps drain the airways of that thick, sticky mucus, and it's done with postural drainage along with percussion and vibration to facilitate draining of this mucus from the lung lobes, and it's followed by that huff coughing. This is a huge part of the treatment for CF patients. And we actually have people that we know that have two kids that have this. One of the kids, and they're twins. The one is a boy, and he has it. He's the same age as my boys. And he has the respiratory part of this. So every day he does this religiously, every day. So they have their own machine at home that does the vibration. He has to do that every day. And they do the chest physiotherapy, all of that. So usually the patients perform this 2 to 4 times a day or more, depending on if they're fighting a lung infection. So sessions can vary 20 minutes to an hour. Okay, other things, you want to prevent infection. So wear a mask due to flu times or when sick. Do really good hand hygiene. Stay up to date with your vaccines. Lung transplant if possible, if the lungs are really severe. Exercise is super important, and these two kids that we know, they do a ton of activities to do exercise to keep their lungs in good shape. So regular aerobic exercise helps to keep the lungs healthy and clear secretions. Educate to monitor sweating because of the risk of losing too much salt. They may need salt supplements and increase caloric needs when they exercise. They do every sport under the sun just to keep their lungs good. All right, and then the girl, so there, this is a boy and a girl. So the girl, she has the GI portion of this. So she doesn't really have the lung issue. She has more of this. So she has to take pancreatic enzymes. She has problems with losing weight a lot, and she just has all kinds of issues with her stomach. So with pancreatic enzymes, you have to swallow them. You don't chew or crush them. If they can't swallow the capsules, you can open them up and put them in food, but it has to be acidic food, like applesauce. You don't mix it in an alkaline-based food like yogurt, pudding, or ice cream because it will inactivate the enzymes. So that's really important to know. And then when they're taking this, how do you know if they're receiving an adequate amount of enzymes? Their stool is not going to look greasy or odorous when they're free from abdominal bloating or pain. So if they're taking enough, that's what things should look like. Their stool should look more normal. Some names of these would be pancreolipase or pancreatin. Some patients have to have feeding tubes because their caloric intake is very high, especially during illness or during the late stages of the disease. High protein and high calorie fat diet with vitamin supplements sometimes. So I know this little girl, she had to have a feeding tube at one point. Obstruction and constipation, that's another thing that she deals with. So you're supposed to drink lots of water, and she, use Miralax. That's a common thing to do. Monitor for bowel obstruction, and then neither one of them, I don't believe, has a problem with diabetes so far, but they could eventually, and it's because your pancreas is damaged. So you would have to monitor your blood sugars all of the time. So that's kind of the basics about the cystic fibrosis. And again, you guys can come on here and look at this and listen to these videos if you want to. So hopefully that helped a little bit. And I'll see you again this coming week here. So have a good 4th of July weekend, and I'll see you guys soon.